esteemed jury, dear participants, listeners, ladies and gentlemen. On behalf of the Student Scientific Society of Medical University of Silesia in Katowice, I would like to thank for coming and taking part in the National Medical Conference of Silesia 2024. My name is Michał Ozierski, and I have honor of moderating this Surgical 1 session. I would like to welcome the esteemed jury, President of the jury, Dr. Agnieszka Kuczej, and the members of the jury, Dr. Sebastian Sirek, Dr. Dariusz Stańczyk, and Dr. Jarosław Paluch. I would like to explain the rules of the session. The order of the presentation will be the same as the abstract book. The maximal time for the presentation is 7 minutes, and the 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on the conclusion and finish the presentation as soon as possible. Esteemed jury, I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please cross out the number on your card. Other members of the same clinic are able to assess the presentation. The assessments will be verified. I would like to remind if the work is presented in English, the discussion also should be run in English. If the commission will ask the question in Polish, the authors of the work are obligated to answer in English. So, these are the rules, and I would like to welcome on stage our first presenter of the work Ultrasonographic Assessment of the Carotid Intima Media Thickness in the students of SUM in Katowice. Please welcome our first presenter with a big applause.
Good morning, esteemed jury and all listeners. My name is Leon Smułka, and I would like to present our work on ultrasonographic assessment of carotid intima media thickness, CIMT, in students of Medical University of Silesia in Katowice. Atherosclerosis is a chronic disease of the arterial vessels. The pathology of it is quite complex. That process is multifactorial and not fully understood yet. However, this disease is increasingly linked to factors such as the level of physical activity or smoking. The intima media complex is a structure located between the echo at the blood vessel wall boundary and the outer edge of the medial membrane. The thickening of the inner membrane is considered as an early stage of atherosclerosis and also as an important indicator of an cardiovascular event. An excellent method of detecting the first adverse structural changes is an ultrasound examination. According to the European Society of Hypertension, the values of CIMT are considered to be 0.9 millimeters. The values exceeding 0.9 are regarded as an initial organ damage. The aim of the study was to assess the relationship between the thickness of the intima media complex in the right and the left carotid artery amongst the medical student population of the Medical University of Silesia in Katowice in relation to lifestyle and family medical history. The study encompasses 100 individuals, both men and women, who are students at the Medical University of Silesia in Katowice. The youngest person interviewed was 20 years old, and the oldest one was 28. They were asked to fill out a questionnaire pertaining to their lifestyle, health conditions, and also family medical history. And here on the slide, we can see the survey template that we used in our research. Subsequently, these individuals underwent ultrasound examination to assess the intima media thickness. All examinations were performed at the Department of General and Vascular Surgery, Angiology, and Phlebology. This was done using a Voluson E8 RSA device with high-resolution linear probe. But what's important, each examination was carried out by the same member of our team to minimize human error. The IM complex was assessed for both the right and the left carotid artery. All measurements were made at the posterior wall, taken at 3 points, and with an average derived from them. Going through the questionnaires, we can see here the amount of people that were dealing with specific conditions or addictions. Generally speaking, I can say that only individuals had the CIMT above the norm, which in fact is completely understandable given the age of the subjects. In our study, we focused on analyzing the changes in CIMT, mostly taking into account lifestyle. And what particularly caught our attention was the aspect of smoking. We observed the relevant differences in CIMT between smokers and non-smokers. For smokers, the average CIMT was much greater, as we can see on this column chart. This box plot over here depicts the spread of the results for both groups. For the right CCA for smokers, we observed that the thickness came out slightly lower since the outliers were included. However, this does not affect the conclusions drawn. Furthermore, we observed the statistical significance in our research. For both cases, the p-value is much lower than 0.05, according to Pearson correlation coefficient and also the student t-test that we used in our research. In addition, I can say that there was also a little positive correlation between the CIMT and BMI or the level of physical activity, but without statistical significance. In conclusion, I would like to say that our research confirmed that smoking has an impact on carotid intima media thickness. But most of all, it emphasizes the validity of measuring the carotid intima media complex using non-invasive methods. Hence, we strongly believe the further research on a larger group, on a larger population, in a wider age of range, should be conducted. Thank you for your attention, and now I'm ready for your questions.
To lecturer, how can you estimate the contribution of students to this study from idea up to the statistical analysis? How can you estimate?
Thank you for your question. In general, I can say that whole research from the start to the end was done by our own. My personal attitude and my personal, I was personally responsible for collecting the data and statistical analysis. But for example, the first author, Karolina Blady, was responsible for doing the USG examinations. Yeah, idea either. Yes, of course.
Another one question. The ultrasound study was performed only by one person, in one person, or
yes. The study was carried out by the same member, the one person of our team, of course, to minimize the human error.
Okay, and another one question. You showed that there was 95% of alcohol drinkers. How did you define it?
Yeah, alcohol drinking is there was a question beginning through the if you are in general alcohol drinker, and then what is the frequency of alcohol drinking. But we observed that there is no statistical significance in that, maybe because of the age of the group, because it's really young.
Thank you.
Thank you very much.
Thank you very much. Yes, do we have the time for another question from the...
Yes. Actually, yes, we did compare our results with the literature around the world. And what we found is talking about smoking is mostly similar. But there was also research with the people of the older age, and then the results could take into account many more risk factors. So it also could be exceeded. Thank you.
Thank you very much. And I would like to welcome on the stage our second presenter of the work, the characteristic and treatment of the lower limb aneurysms. Big applause, please.
Dear commit members, ladies and gentlemen, my name is Magdalena Monka, and I'm here to present you our study about surgical treatment of lower limb through and pseudoaneurysm. Aneurysm are characterized by an outward bulging, abnormal widening, or ballooning of the blood vessel that exceeds 50% of the vessel normal diameter. They are distinguished by the structure of the wall, with pseudoaneurysm consisting of tissue surrounding the artery. In contrast, true aneurysm have a wall made of all of three layers of the artery: intima, media, and adventitia. There are several methods of treatment of aneurysm. Active observation may be used in asymptomatic aneurysm. They can be treated endovascularly by endovascular aneurysm repair. There are also surgical methods that can be used, that is aneurysmectomy and an extra-aortic bypass. Sometimes aneurysmectomy and extra-aortic bypass are combined. And now I will briefly explain to you what these methods are all about. Aneurysmectomy consists of surgical extension of bulging of weakened portion of the artery. In most cases, a synthetic graft is used to replace the removed portion of the blood vessel and to restore its continuity. During this procedure, a detour or bypass is created outside of the affected part of the blood vessel to reroute a blood flow around the aneurysm. Firstly, the aneurysm is ligated in a distal and or proximal side. Then the graft is carefully attached to the healthy blood vessel segments. To create a bypass, a synthetic graft or venous vessel is used. EVAR, which involves a deployment of endovascular stent graft, typically begins with the insertion of the catheter into the femoral artery. The catheter then is guided through the blood vessel to the site of the aneurysm. Subsequently, the graft is positioned within the aneurysm, effectively seeing a weakened portion of the blood vessel and creating a new pathway for the blood flow to prevent any further expansion of the aneurysm. Now let's move on to the aim of our study, which is to clinically characterize lower limb aneurysm and analyze perioperative short-term, long-term outcomes of the surgical treatment of lower limb aneurysm in period 2018-2023. We perform a retrospective analysis of 110 patients. All of them were treated in the Department of General Surgery, Vascular Surgery, Angiology, and Physiology in period 2018-2023. We collect data about risk factors, aneurysm size and types, and complications of treatment. We also made a follow-up using data from surgical clinic. 64.5% of patients was diagnosed with true aneurysm, while 35.5% with pseudoaneurysm. We observed that more males was diagnosed with true aneurysm compared to pseudoaneurysm. In addition, a general atherosclerosis was more often reported in pseudoaneurysm group, while for the others comorbidities, we observed no significant differences. Let's move on to symptoms. Acute lip ischemia was more often a symptom of, acute lip ischemia was more often a symptom of true aneurysm than pseudoaneurysm, while for the rest of occurrence of rest symptoms, we found no significant differences between both groups. So there was no significant differences in aneurysm size between both groups, with media 36 millimeters in true aneurysm and 35 millimeters in pseudoaneurysm group. In terms of localization, popliteal artery was more often the localization of true aneurysm, while the common femoral artery, pseudoaneurysm. Pseudoaneurysm was treated by aneurysmectomy and aneurysmectomy with bypass, while EVAR and surgical bypass was more often performed in true aneurysm group. So in comparison of surgical characteristic, we had no significant differences between both groups, with similar intraoperative blood loss, duration of the procedure and duration of the hospitalization, numbers of complications, and 30 days mortality. So we perform a univariate logistic regression analysis of listed variables to find independent predict factor for early postoperative complication. Only the occurrence of general atherosclerosis proved to be independent predict factor. And here we perform our graphical results. In the follow-up period, we observed a total of 27 complications, with similar occurrence between both groups. In addition, 3 patients die, one due to acute heart failure, another due to intracerebral hemorrhage, and the last one due to traffic accident. So, due to the occurrence of the additional late complication, we perform a Cox proportional hazard regression analysis with listed variables to find predict factor for combined reoperation, amputation, graft stenosis events. In the univariate model, the occurrence of the aneurysm in popliteal and common femoral artery, as well as aneurysm size, proved to be a significant factor impacting the occurrence of RAS events. Therefore, we perform a multivariate analysis with these variables to find independent predict factor. As you can see, only the occurrence of aneurysm in common femoral artery with hazard ratio 0.1, as well as aneurysm size with hazard ratio 1.1, proved to be independent predict factor. So let's move on to the conclusion. Symptoms of LLA are mostly non-specific and can be easily overlooked, leading to late diagnosis of the disease. Most true aneurysm occur in the popliteal artery, while pseudoaneurysm occur in common femoral artery. Both open surgical as well as endovascular procedures can be performed in patients treated for LLA. However, further studies are needed for endovascular procedures in the treatment for lower limb pseudoaneurysms. The occurrence of atherosclerosis may be a positive predict factor for the occurrence of early complications. And the occurrence of adverse events should be considered in patients undergo a surgical treatment for LLA. Therefore, a regular follow-up is needed. Thank you for your attention. If you have any questions, we will gladly answer them.
Okay, can we start? Thank you very much. Very nice presentation. Maybe it's easy question and maybe it's easy answer, but when we talk about the group 110 patients, we will see 95 men and only 50 women. Why the difference that is like this? Why only 50 women in this group?
I think it's due to the lifestyle
General.
In general,
Genetic.
yes, more men are smoking and drinking alcohol, and it's especially in pseudoaneurysm group, it's the most common cause of the aneurysms.
Okay, and next question about your own contribution of this study.
Collecting and analyzing data, also interpreting them, and made this presentation.
As well as me, and we also assist in some of the procedures.
And the statistical analysis, did you perform it personally? The statistical analysis, did you perform it?
Yes, I performed it myself.
Thank you very much. Okay, before the next presentation, I would like to please all the next presenters, when you are answering the questions, please stand right here, because then you are visible to our online guests. I would like to welcome on the stage our next presenter, the presenter of the work Analysis of Factors Affecting Voice Rehabilitation in Patients with Voice Prosthesis. Okay, this is the presentation conducted online. Karolina Pasieb, do you hear us?
Yes, I hear you.
Yes, okay. Please share with us your screen. Okay, we can see.
Do you see my presentation?
Yes, we see your presentation. You can go to the full screen mode and you can start.
Okay. Is this right now in full screen mode?
Yes, it is in the full screen mode. Good luck.
Dear committee, dear participants, my name is Karolina Pasieb, and I will give a presentation, Analysis of Factors Affecting Voice Rehabilitation in Patients with Voice Prosthesis. Approximately 10% of patients after total laryngectomy with voice prosthesis insertion do not rehabilitate voice. Voice prosthesis is a one-way valve. It enables the air passage from trachea to esophagus. Then the air travels up to the pharynx, where vibration of the mucosa of the lateral pharynx wall act as a vocal cord, and the tracheoesophageal voice is produced. Aim of our study was to identify the potential factors influencing the effectiveness of the voice rehabilitation. Medical records of patients who underwent total laryngectomy between January 2020 and July 2023 were analyzed. Selected study group consists of 45 patients and control group consists of 40 patients. Both groups were compared on the basis of potential determinants influencing the effectiveness of voice rehabilitation, such as age at surgery, regular prosthesis replacement, number of prosthesis replacement, and number of complicated prosthesis replacement. Comorbidities such as GERD, diabetes mellitus, and lung diseases. Pre- and post-operative radiotherapy and post-operative radiochemotherapy. Statistical analysis reveals neither age nor gender are determinants of the effectiveness of voice rehabilitation. Also, comorbidities are not a risk factor of ineffective voice rehabilitation. Surprisingly, pre- and post-operative radiotherapy and post-operative radiochemotherapy do not emerge as risk factors. Patients from the study group experience statistically significant more often difficulties during prosthesis replacement in comparison to the control group. This is why special attention should be directed toward this group of patients, as they exhibit an elevated risk of developing voice rehabilitation disorders. Patients from this group experience numerous attempts to replace the voice prosthesis, replacement performed using bougie, or replacement performed in the operating theatre. I would like to emphasize that presented results are preliminary. Our study is still ongoing, and our, as a team, ultimate goal is thorough analysis of the anatomical and functional causes of ineffective and unsuccessful voice rehabilitation. Limitations of our study are small sample size, single center study, retrospective study design, and lack of regular monitoring of the patient's overall health status. Interdisciplinary analysis of risk factor is crucial. What's more, further studies should be conducted to determine risk factor and to create a robust guidelines how to effectively assist patients in voice rehabilitation. Thank you for your attention.
Thank you for your presentation. Now it's time for the questions from the jury.
I have a question to the presenter. While considering indications and contraindications to implantation of such prosthesis, we have to think about, especially about social status of the patient, as you know, because it is necessary to clean twice a day this kind of prosthesis. And as everybody know, some of these patients who suffer from laryngeal cancer, there are people who previously used alcohol and smoked tobaccos. And it's necessary to think about the social status of patients. Thank you.
Thank you for your question. Yes, that's true. That's why also thorough education to this patient before operation is crucial, and then the process of explaining why it's so important to clean the valve and to be really cautious when it comes to the whole fistula, to avoid infection and other complication in the process of healing, and then maintaining the valve and the fistula.
Yeah, and I think it's necessary to include the didactic process family of patient. It's very, very important.
Yeah, I agree.
You have any other questions? So thank you very much for the presentation.
Thank you very much.
And I would like to welcome on the stage our next presenter of the work, Can Studying Medicine Compromise the Lower Limb Venous Outflow and Increase the Risk of Venom Thrombosis?
Good morning, ladies and gentlemen. My name is Monika Bączek, and I am honored to present you our work titled Can Studying Medicine Compromise the Lower Limbs Venous Outflow and Increase the Risk of Venous Thrombosis? During my presentation, I would like to try to answer this question. But let me begin my speech with a shortly theoretical introduction. So the correct venous outflow depends on many factors, such as, for example, skeletal muscle pump, and the disturbances in this outflow may lead to consequences such as deep vein thrombosis, or it may increase the severity of the chronic venous disease. As you can see, deep vein thrombosis is still a huge problem in medicine, and it is estimated that every year in European Union died more than 500,000 of patients due to this disease. And to show the range of this problem, this is somehow like twice the population of Katowice, so this is really a huge number of people. One of the group of the increased risk of deep vein thrombosis is the group of patients that are immobilized. For example, patients that are hospitalized for a long time, but not only this group of people have the increased risk. Nowadays, you can find more and more articles about e-thrombosis. This is the term connected with the deep vein thrombosis that occurs in people that are long-term immobilized in the front of the computer. One of the group of people that spend long hours in front of computer are medicine students because they learn for a long hours. So it brings us to the question, can studying medicine compromise the lower limb venous outflow and increase the risk of venous thrombosis? So the aim of our study was to analyze students' behavior and their favorite sitting position while studying. Then we also want to know how sitting positions during studying affects venous outflow in lower extremities. Moving on to the materials and methods, our study consisted of 2 stages. The first one was an online anonymous survey, which was addressed to the medicine students, and we collected data about personal information, deep vein thrombosis risk factors, also about study habits and their favorite sitting position. Then we move on to the Doppler ultrasound examination, which was performed on 22 years old medicine student in the most frequently indicated by students' position. And during this examination, we measured the peak velocity, time average velocity, and we want to assess also the venous outflow spectrum characteristic. Our study group consisted of 108 students from all years of medicine. The average the age range was from 19 to 32 years old, and there were mostly female. What is interesting, more than nearly half of the students has other risk factors of deep vein thrombosis, and the most common are hormone usage, smoking, and obesity. Moving on to the results. Most of the respondents admit that they study at least from 3 to 4 hours per day, so they spend this time in the front of the desk because this is their favorite study place, and they are immobilized. What's more, almost all students use the computer or their laptop not only for studying, but also for entertainment purposes. Moving on to the results of our survey, students also indicated that their favorite sitting position is cross-legged position, sitting on knees, and crossed legs. And now I would like to show you the results of our examination. And here is a short video. So the first trial was conducted on a 22-year-old healthy volunteer in the standing position. And we noticed during this trial that the venous flow is changing with respiratory action. The peak velocity was up to 8 centimeters per second, and the time average velocity was 5 centimeters per second. The next one position was most frequently indicated by student position, and it was cross-legged. And we find out that it is also in this position also venous flow changes with respiratory action, but the peak velocity and time average velocity is higher, and it is a result from the compression of popliteal vein. So the outflow is disturbed. Now let's move on to probably the worst sitting position while studying, and it is sitting on knees. As we can see, there is no respiratory action changes of the venous flow. The peak velocity and time average velocity is really decreased. This is because of the extensive compression of popliteal vein and vein located in calf, and this position is most dangerous for students while studying. And the last position was cross-legs position. And this one, surprisingly, is most similar to the physiological venous outflow while standing, because the peak velocity is up to 8 centimeters and the time average velocity is 4 centimeters per second. Now let's come to the conclusion. So while studying, medicine students most often choose position with improper leg placement, which reduces the venous outflow and increase the risk of venous thrombosis. What's more, sitting on knees is the worst positions while studying, and it should be avoided by the students. Ladies and gentlemen, this brings us to the end of my presentation. Thank you very much for your attention, and please feel free to ask me questions.
Thank you for the interesting presentation. I have one question. Do you think that if you collect more data from the probants, it would be change the results of your study? Not only one person as a healthy volunteer, but about 10 patients or 10 other students that are without risk factors?
Maybe it can shoot the results, but probably the rules are the same, because when somebody is sitting on calves, there is the most compression of veins, not only in the popliteal fossa, but also in the calves. So the compression is the higher, but when we are sitting in the cross-legged, we also have a compression in the popliteal fossa. So I think that the number of volunteers do not play a huge role in this study.
One question about prevention. What we can do? Like medical students spend 3-4 hours per day, so maybe break like 50 minutes break, and after that's 2 hours with the work in the desk.
Yeah, we think that this is a great idea, and we should sit in a straight position or cross-legged position and avoid sitting on calves. And I agree that we should do breaks after, for example, a 1-hour study, and spend these breaks actively.
Okay, thank you very much.
Do we have any other questions? So thank you very much. And I would like to welcome on the stage our next presenter. The next work will be Acute Appendicitis on Experience of Doctors at the University Clinical Hospital in Wrocław from 2023. Big applause.
Drodzy Państwo, Szanowna Komisjo, nazywam się Oliwia Stefaniak i razem ze Śminą Nowak chciałybyśmy przedstawić Państwu statystyki na temat pacjentów, którzy zostali poddani zabiegowi appendektomii w roku 2023 w Szpitalu Klinicznym we Wrocławiu. I tak, według statystyk, mimo rozwijającej się diagnostyki obrazowej, diagnostyka ostrego zapalenia wrostka robaczkowego nadal jest ciężka. Według statystyk błąd przy diagnostyce popełnia aż 30% rezydentów i nawet 10% lekarzy specjalistów. I właśnie te trudności w diagnostyce stały się podstawą do naszej pracy. Jako materiał do naszej pracy wzięłyśmy 121 pacjentów, którzy w roku 2023 zostali poddani zabiegowi appendektomii w Szpitalu Uniwersyteckim we Wrocławiu i badanie histopatologiczne potwierdziło u nich obecność zmian zapalnych właśnie w wyrostku robaczkowym i ich historię leczenia porównałyśmy z danymi z innych ośrodków w Polsce, które również przeprowadziły takie statystyki w ostatnich latach. I tak, jak Państwo widzą, w 2023 roku Oddział Chirurgii Ogólnej i Chirurgii Onkologicznej we Wrocławiu przeprowadził 1331 operacji, z czego 121 to zabiegi appendektomii. Z tego widzimy, że prawie co 10. zabieg to appendektomia, a mimo wszystko ta diagnostyka jest tak trudna i często nieskuteczna. I z takich danych demograficznych, no to 66% naszych pacjentów stanowili mężczyźni, a połowę z tego kobiety. Średni wiek naszych pacjentów to około 39 lat. Mniej więcej tak samo dla mężczyzn oraz dla kobiet i jest to około prawie 10 lat więcej niż dane z innych ośrodków. Tam na przykład wskazywały na 27-28 lat. I tak, jeżeli chodzi o czas hospitalizacji, to średni pacjent w Szpitalu Uniwersyteckim we Wrocławiu po zabiegu appendektomii spędził około 5 dni. Przy czym ta średnia była znacznie wyższa dla kobiet i mogła być spowodowana licznymi komplikacjami ginekologicznymi, na przykład zapaleniem przydatków. I tak, jeżeli chodzi o choroby współistniejące u naszych pacjentów, to taką najczęstszą, którą zauważyłyśmy, jest autoimmunologiczne zapalenie tarczycy Hashimoto występujące u kobiet. I tutaj na 40 kobiet, których historię przeanalizowałyśmy, aż 23 w wywiadzie podały właśnie, że cierpią na to schorzenie. 6 z nich cierpiało na IBS, czyli zespół jelita drażliwego. Jeżeli chodzi o mężczyzn, to tutaj bardziej zauważalne były choroby cywilizacyjne związane z ich stylem życia, takie jak nadciśnienie czy też cukrzyca, głównie cukrzyca typu 2. I tak, jeżeli chodzi o używane metody diagnostyki obrazowej, no to tutaj mimo tego, że jak wiemy badanie ultrasonograficzne jest tym badaniem pierwszego rzutu, no to w naszym szpitalu większość tych pacjentów jednak została zdiagnozowana na podstawie badania tomografii komputerowej, ponieważ została ona wykonana u 73% pacjentów. Badanie RTG zostało przeprowadzone jedynie u jednego pacjenta, to był mężczyzna z podejrzeniem perforacji jelit. I tak, jeżeli chodzi o lokalizację naszego wyrostka, no to 105 wyrostków zostało określone jako wewnątrzotrzewnowe, wyrostki międzypętlowe, wyrostki wstępujące do miednicy mniejszej lub te wstępujące do wątroby. Te wyrostki zakątnicze, zewnątrzotrzewnowe, takich wyrostków znalazłyśmy tam jedynie 16 i mniej więcej te statystyki zgadzają się z danymi ogólnopolskimi. I jeżeli chodzi o średnicę naszego wyrostka, no to taką normą, którą znalazłyśmy w artykułach, jest 7 mm. Średni wyrostek na naszym oddziale miał około 10 mm. Największy wyrostek, do którego dotarłyśmy, miał 17 mm. I tak, jeżeli chodzi o wyniki krwi naszych pacjentów, no to stale był u nich podwyższony poziom białka sera aktywnego, nawet do 600 mg na litr, a jeżeli chodzi o leukocytozę, no to tutaj odnajdywałyśmy zarówno wyniki takie powyżej normy, dochodzące aż do 24 mg, jak i zarówno pacjentów z leukopenią, co mogło wskazywać na zgorzelinowe zapalenie tego wyrostka. Jeżeli chodzi o powiększone węzły chłonne, no to takie znalazłyśmy jedynie u 47% pacjentów, których historię choroby analizowałyśmy. Jeżeli chodzi o obecność kamienia kałowego w świetle wyrostka, no to tutaj jako powód tego zapalenia był obserwowany on jedynie w badaniach u 19 pacjentów, czyli u zaledwie 15% tej grupy. I przechodząc do objawu odrzewnowego, czyli objawu Blumberga, no to tutaj wystąpił on jedynie u 52 pacjentów, czyli u zaledwie 43%, co naszym zdaniem bardzo podważa skuteczność diagnozowania właśnie OZWR metodami punktowymi, na przykład klasyczną skalą Alvarado, w której zajmuje on dosyć wysokie miejsce. Jeżeli chodzi o objawy, które wystąpiły u pacjentów bez tego objawu odrzewnowego, objawu Blumberga, no to najczęściej były to właśnie mdłości lub też wymioty. I przechodząc już do najważniejszej części, czyli do wyboru leczenia chirurgicznego, no to tutaj u 99 pacjentów zabiegiem była laparoskopowa apendektomia, co stanowiło prawie 82% i ze względu na krótszy czas hospitalizacji takich pacjentów i mniejszą ilość powikłań, na przykład zakażeń rany operacyjnej. Tradycyjna laparotomia z cięcia McBurneya została wykonana tylko w 22 przypadkach, przy czym 13 przypadków to były zabiegi konwersji z dostępu laparoskopowego. I tutaj chciałam zwrócić uwagę na średni wiek tych pacjentów, którzy byli poddawani właśnie operacji w sposób tradycyjny. I jest on znacząco wyższy niż średni wiek całej grupy, co potwierdza doniesienia z innych ośrodków w kraju, że w przypadku pacjentów starszych tutaj bardziej niż powikłań po laparotomii boimy się dopuszczenia do tej perforacji wyrostka. I przechodząc do podsumowania, analizując historię naszych pacjentów, dotarłyśmy do danych, że więcej osób, które zapadały na ostre zapalenie wyrostka robaczkowego, to mężczyźni w wieku około 40 lat. Badaniem, które było wykonywane częściej i na podstawie jego była stawiana diagnoza, była tomografia komputerowa, a objaw Blumberga nie był wspólny dla wszystkich pacjentów. Dziękuję bardzo.
Bardzo dziękuję za tę prezentację i teraz prosimy o pytania od jury.
No to ja mam tylko pytanie o ten czas hospitalizacji kobiet i mężczyzn, bo tam znacznie wydłużył się w przypadku pań. Czy to tylko te przyczyny ginekologiczne i czy te wszystkie panie, które były badane wtedy miały to zapalenie przydatków, czy tam też inne były powody i gdzieś tam się doszukiwaliśmy do tego?
Znaczy na pewno nie wszystkie, ale właśnie bardzo rzuciło mi się w oczy, że tam było na przykład jakiś naciek zapalny na prawy jajnik. To było chyba w 4 przypadkach, pamiętam, że coś takiego i właśnie były to też kobiety na przykład przekazywane z oddziału ginekologii, na przykład właśnie na oddział chirurgii i właśnie to bardzo nam się rzuciło w oczy, że często są te problemy ginekologiczne i to sprawia, że te kobiety tak długi czas spędzają na tych oddziałach.
Ja mam jeszcze kolejne pytanie. Proszę mi powiedzieć, kto badał ten objaw otrzewnowy? Chirurg czy lekarz SOR-u, izby przyjęć? Przez kogo był oceniany ten objaw Blumberga?
Na podstawie tych opisów wydaje mi się, że był to lekarz z SOR-u.
No to tutaj tylko dodam, że no, na podstawie naszego doświadczenia ocena objawu otrzewnowego, nie tylko Blumberga, ale innych objawów przez lekarza chirurga i przez lekarza SOR-u czy lekarzy z innych oddziałów jest niestety diametralnie różna. Także może dlatego tam ma pani doktor taką dużą różnicę. Drugie moje pytanie, czy Państwo mieliście dostęp do tego, ile procent wyrostków było niezmienionych z tych wyciętych? Czy jest jakaś taki odsetek, który wyszedł w status normalis, że doszło do pomyłki?
Nie, tutaj akurat nie było zaznaczone, żeby w badaniu histopatologicznym wyszło, że ta struktura jest niezmieniona.
A jaka była najczęstsza przyczyna jakby pomyłki diagnostycznej? Że to nie był wyrostek, że to nie było ostre zapalenie wyrostka, tylko inna przyczyna? Nie ma pani doktor takiej?
Nie.
Okej, dziękuję.
Podziękować. Taki temat powszechny, ale nie banalny w chirurgii. Nie jestem chirurgiem, laryngologiem jestem, ale ze swojego stażu i to kolega popieram taką kwestię. Państwo jesteście teraz, wejdziecie w świat medycyny i to badanie fizykalne, które może nie schodzi na drugi plan, ale jest wypierane w tych procedurach naszych medycznych, w tych algorytmach i rekomendacjach. Jest to nieco inna medycyna niż była, kiedy ja kończyłem studia. Ale do czego zmierzam? Kiedy byłem na stażu i w szpitalu, w którym byłem na stażu, dyżurowałem, w trakcie dyżuru na chirurgii operowano 5 ostrych wyrostków. Mówię ostrych, bo jeszcze są oczywiście przewlekłe z zaostrzeniem, nieco inna klinika jest tego schorzenia. I nie było wtedy dostępnego żadnego obrazowania na dyżurze, nawet nieraz USG. Chirurg miał do dyspozycji oczywiście wywiad, badanie podstawowe krwiooobwodowe, gdzie zwraca uwagę na leukocytozę, oczywiście parametry stanu zapalnego. I powiem, jak to wyglądało. Chirurg badał, zbierał wywiad, badał fizykalnie badania dodatkowe i prosił kolegę nieraz, nie mówiąc mu w ogóle o tym chorym, jaki jest wywiad, mówi, dotknij brzucha, co myślisz? I wtedy była taka ślepa próba. On dotykał, to widziałem wielokrotnie i wtedy dopiero była ta konkluzja co do operacji. Jak mówię, badanie li tylko fizykalne przez ten staż, który tam byłem i widziałem te otwarte, mówiąc kolokwialnie, brzuchy, pomyłka była bardzo rzadko. A jeszcze powiem Państwu taką kwestię. W klinice na francuskiej, gdzie pracuje pan profesor świętej pamięci, przez nas dobrze jeszcze pamiętany Kokot, Franciszek, na wizycie, pamiętam to doskonale, byłem tam na konsultacji, pan profesor Kokot, przechodząc przez korytarz, stały pojemniki z moczem, 5 pojemników z moczem. Podszedł, potrząsnął, poglądał, powąchał, 5 pojemników. Tu jest takie schorzenie, takie. Telefon, za 2 dni telefonuje kolega i mówi, Jarek, słuchaj, wszystkie 5 się zgadzają. Mówię to Państwu po to właśnie, żebyście jako młodzi lekarze nie epatowali się algorytmami, nie epatowali się oczywiście pewnymi standardami, ale tą medycynę fizykalną, tą najprostszą i wywiad mieli w pamięci, bo wtedy, jeżeli tą nowoczesną technologię połączymy z tą rzetelnością taką podstawową, którą powinniśmy wynieść, tą takim rzemiosłem podstawowym w badaniu fizykalnym, to wtedy te statystyki na pewno będą znakomite. Dziękuję.
Dziękuję bardzo.
A skala Alvarado jest naprawdę dobra w praktyce klinicznej. Dziękuję.
Dziękuję bardzo.
Bardzo dziękujemy. And ladies and gentlemen, I would like to welcome on the stage our next presenter. The next work will be cationic nanoemulsions and dexapentanol versus dexapentanol plus Harper-Mallows in the healing process following ABK.
Good morning. Hello, medical students, esteemed medical faculty. My name is Natalia Kwaśniewska, and it's great to be here and have a chance to present my research. The concluded study analyzed the influence of Harper-Mallows, cationic nanoemulsion, and dexpantanol on the healing process of corneal epithelium after Epi-Baumann keratectomy. Epi-Baumann keratectomy is a surface ablation technique. It consists of corneal epithelium removal with EpiClear epikeratectomy, which is a single-use blunt device. It leaves Baumann's layer intact, and prepares treatment zone for laser photoablation. Unfortunately, every type of refractive surgery decreases the population of goblet cells and damages corneal nerves, which leads to the loss in corneal sensation. This leads to reduced tear secretion, blinking, and reduced ocular surface moisture. These findings contribute to development of dry eye syndromes, and there are many different ways to treat that. This study, the aim of it was to investigate the influence of eye drops on postoperative early stage healing process of corneal epithelium after Epibauman keratectomy. The patients were split into two subsets. The first group received cationic nanoemulsion and dexpanthenol as two separate products, whereas the second group received dexpanthenol and hypermalloz, which were administered as one combined product. The study included 32 patients who had myopia or myopic astigmatism that summed up to 63 eyes because one patient wasn't one-eyed, but because he had correct vision in the second eye. 21 patients received cationic nanoemulsion and dexpanthenol as an adjuvant treatment after the procedures, whereas the rest of the patient, that is 21 eyes, received dexpanthenol and hypermalloz. Inclusion criteria were myopia, myopic astigmatism, stable refractive error for more than 2 years, age above 21, and consent to undergo Epibauman keratectomy. And the exclusion criteria were ocular trauma, previous intraocular surgery, active inflammatory eye disease, and ophthalmic pathology, which is significant. The procedures were performed by skilled ophthalmic surgeons with the use of excimer laser. After surgery, a bandage contact lens was applied for 7 days. A postoperative regimen included levofloxacin drops 5 times per day, dexamethasone drops twice daily, and chosen eye drops 5 times per day. Uncorrected and corrected visual acuity and pachymetry were assessed 1 week before and 1 week after the procedure. Additionally, corneal epithelialization and subjective assessment of visual blur, pain, and other discomforts were also evaluated 1 week postoperatively. The mean age for dexpanthenol and hypermalloz group was 32 years, whereas for dexpanthenol and cationic nanoemulsion, it was 29 years. There was no statistically significant differences found between the groups in spherical equivalent, age, and pachymetry thinness. Statistical analysis was performed with the use of RSoft and Excel, and non-parametric Mann-Whitney U-test was performed to test for the differences in distribution between the data in groups in preoperative data, postoperative visual acuity, pain level, epithelial defect, and spherical aberration. A paired Wilcoxon signed rank test was performed to compare postoperative and preoperative spherical aberration and visual acuity. A p-level less than 0.05 was considered statistically significant. As you can see, there was no statistically significant difference in the uncorrected visual acuity 1 week postoperatively between those two groups. And when it comes to corneal erosion, the findings are also similar. Both groups had the same percentage of no erosions in corneal epithelium after 1 week. The hypermalloz and dexpanthenol groups had slightly higher percentage of small erosions in corneal epithelium after 1 week in comparison to the second group, but also had no large erosions. There were no statistically significant differences between the groups also when it comes to spherical aberration and pachymetry thinness 1 week postoperatively. The dexpanthenol and cationic nanoemulsion group had slightly higher occurrence of blurry vision, whereas the dexpanthenol and hypermalloz group had slightly higher percentage of pain occurrence. Summarizing, both groups had similar uncorrected visual acuity post-operatively and degree of corneal erosion. However, using only one product instead of two increases patients' comfort and may increase adherence to treatment. Thank you for your attention.
Thank Thank you very much. And it's time for the questions from the jury.
Question, are the two solutions available as a standard of care or it's an experiment?
It's not exactly an experiment because these eye drops are an adjuvant treatment. So it's not necessary to use them because the most important is, of course, levofloxacin and steroids to use after the procedure. However, they may improve patients' comfort and different physicians use different eye drops while performing after the surgery. So you can choose. Thank you. Thank you for your question.
Do we have any other questions? Okay, thank you very much. And our next presenter will be the presenter of the work, The Impacts of the Menstrual Cycle Phase on the Chronic Venous Insufficiency Symptoms in Women aged 20-25 years. Welcome on the stage. Ladies and gentlemen, please, a big applause for the presenter.
So good morning. My name is Ewa Góralczyk, and I have the pleasure to present you with our study on the effects of the menstrual cycle phase on the occurrence of chronic venous disease symptoms in young women. So the chronic venous disease is a disorder of the peripheral venous system that leads to the stasis of blood in the limbs. There is a scale, the CEAP scale, that was first described in 1994, that is now commonly used to describe the clinical manifestations, etiology, anatomical localization, and the pathophysiological causes behind this disease. When it comes to the clinical manifestations, there are 6 stages in the scale. And they are from the C0, which means there are no palpable or visible signs of this disease, and C6, which means there's an active ulceration. Chronic venous disease is the result of blood stasis and venous hypertension. It can be caused by many conditions, such as the following: impaired function of the venous valves, hormonal disorders, and the venous thrombosis, which causes the occlusion of the veins. The aim of our study was to determine whether the phase of the menstrual cycle has an effect of both the occurrence and the severity of the chronic venous disease symptom in young female population. We recruited 117 women between the ages of 20 and 25. None of them has ever been pregnant, and they were not currently on any form of hormonal contraception. In stage 1 of our study, we created a survey which was based on the CEAP scale, and we asked the women to rate the severity of the symptoms based on the scale. And we classified some of those women as symptomatic. And to be classified as symptomatic, they had to report at least 3 subjective or 1 objective symptoms and rate them as the severity is 5 or more. In the second phase of our study, we asked the symptomatic women to observe their symptoms throughout the whole month and then rate the severity, but this time in relation to the phase of the menstrual cycle. In the first stage of our research, we found out that out of those 117 women, 41 of them could be classified as symptomatic, and that means 35%. The most commonly experienced symptoms were the feeling of heaviness in the lower limbs, the feeling of fatigue, and the feeling of swelling in the lower limbs. And here you can see how many % of women rated a certain symptom as 5 or more in terms of severity. And as I've mentioned before, in the second phase of our study, we asked those symptomatic women, the 31 women from the first phase, to observe their bodies throughout a whole month and then rate those symptoms in terms of severity, but this time in relation to the hormonal cycle phase. And for instance, when it comes to the feeling of fatigue in the lower limbs, you can see that in the menstruation phase, 68% of women rated this, the severity of this symptom as 5 or more. In the follicular phase, it was 24%. In the ovulation, it was 35%. And in luteal, it was 38%. So the most severe symptoms were in menstruation and luteal phase, and they tended to alleviate in the folliculation and during ovulation. And we actually observed the same exact pattern in other symptoms, such as the feeling of heaviness in lower limbs, the feeling of swelling or edema in the legs, and also pain in the lower regions of the legs, especially during standing or sitting. And you can see here the rest of the symptoms and how many women in percents rated the severity as 5 or more. And the only symptoms that did not follow the exact same pattern, as I've mentioned before, are the night cramps of the legs, restless leg syndrome, and swelling of the legs, and also persistent itching. Every other symptom was following the same pattern that I've mentioned before. And here on this diagram, you can see how many percent of women rated a severity of a certain symptom as 5 or more, and how it changed throughout the menstrual cycle from the menstruation to luteal phase. And from the top to the bottom, those symptoms are the feeling of fatigue in the lower limbs, especially during extended periods of standing or sitting, the feeling of heaviness in legs, the subjective feeling of edema, and pain in the lower limbs, especially during standing. The conclusions that we can draw from our study are following. Chronic venous disease symptoms occur in young female population. Those symptoms are affected by the menstrual cycle, and they tend to get the worst during menstrual phase and luteal phase, and they tend to alleviate during the follicular phase and ovulation. Thank you for your attention. Now I can answer any questions you have.
How many smokers was there in your group?
So we asked those women in the first phase about smoking, and I think it was less than 10 were actively smoking. More than 2 cigarettes a week, I think, or 1 cigarette a week. It was in the question.
You should take this group away from all population, because smoking is a very high risk of some increasing factor of increasing occurrence of symptoms of chronic venous disease. And another question, if you know when the symptoms occurs, do you have any ideas what to do in life to prevent those symptoms?
I think it would be advised from those women who classify to the symptomatic group to avoid any risk factors such as obesity and smoking, as you've mentioned before, and also having regular exercise activity, because they started developing these symptoms in such an early age, so they should be aware. And when it comes to the phase in the menstrual cycle, I think it would be best to, as I've mentioned before, have regular activity and avoid smoking.
Maybe compression therapy?
Yes, and also that.
Okay, thank you.
Do you have any more questions? Venous insufficiency, I've mentioned before the CAP scale, and when it comes to insufficiency, it is the last stage of the venous disease, and there is the CAP scale, and from C3 to C6, when it comes to clinical symptoms, it is classified as insufficiency. And C3 means there is varicose veins and reticular veins. C4 is varicose veins. C5 is an healed ulceration, and C6 is an not healed ulceration. Thank you.
Thank you very much. And we move on to our next presenter. The presenter of the work, what should doctors and medical students know about anthrothrombotic prophylaxis methods?
Good morning, everyone. My name is Dominik Sikora, and I'm pleased to present a work entitled What Should Doctors and Medical Students Know About Antithrombotic Prophylaxis Methods. Venous thromboembolism is a common condition presenting as deep vein thrombosis and pulmonary embolism. It is responsible for 10% of all hospital deaths, which are due to pulmonary embolism. Moreover, 1% of all hospital deaths are due to pulmonary embolism. Strategies for preventing deep vein thrombosis encompass both pharmacological methods and mechanical methods. Mechanical methods are used mainly when pharmacotherapy is contraindicated, and is also often combined with pharmacotherapy for better results. The slide shows us a fragment of guidelines regarding prevention of VTE in the groups of non-surgical patients and surgical patients. The fragment highlighted in red suggests that guidelines for non-surgical patients equate using graduated compression stockings with the use of intermittent pneumatic compression. And additional problem is that many doctors compare these methods as having similar effectiveness. Therefore, we decided to investigate this topic and check whether these methods have the same effect on the venous blood flow. So our study aims to compare different VTE mechanical prophylactic methods to determine their effects on the venous blood flow. We conducted a study on a healthy volunteer while maintaining the same methodology. We compare the following 5 clinical scenarios. We examined patient without compression, patient with belonging stocking, patient with tie length graduated compression stockings, patient with intermittent pneumatic compression, and finally, patient with electrical calf muscle stimulation. We assessed our data using Siemens Accuson X300 with linear probe and dedicated vascular software. We evaluated maximum velocity and minimum volume flow in the femoral vein and also the character of the flow spectrum. What is important during our examination, the participant was in supine position, keeping his emotions calm, limbs relaxed, and breathe as steady as possible. We evaluate passive methods like below-knee stockings and tie length graduated compression stockings, and active methods such as intermittent pneumatic compression and electrical calf muscle stimulations, which activate the calf muscle pump, thereby enhancing the blood flow within the femoral vein. In the case of patient without compression, we can see the respiratory action modulated flow in the femoral vein. In the case of patient with below-knee stockings, we can also notice the respiratory action modulated flow without any special changes related to the application of the device. And additional observations present in the case of tie length stockings. There are no specific alterations connected with the application of the device. On the subsequent slide, we can see the implementation of active method, namely intermittent pneumatic compression. And we can see the clear change in the spectrum of the venous outflow with heightened peak flow velocity and improved flow within the femoral vein. And on this slide, you can see the implementation of electrical calf muscle stimulation. We can see a clear change we can see a shift in the spectrum with heightened peak flow velocity and also improve the flow within the femoral vein. So we decided to compare the obtained data. So now we can proceed to the results. As you can see, there are some differences between passive methods like below-knee stockings or tie-length graduated compression stockings and active methods such as intermittent pneumatic compression and electrical calf muscle stimulation. The highest results of maximum velocity are observed in the cases of patients with electrical calf muscle stimulation and intermittent pneumatic compression. A crucial finding from our study is that not only the peak flow velocity, but also minute volume flow in the femoral veins varies across the methods employed. The highest results was achieved in the case of patients with electrical muscle stimulation and intermittent pneumatic compression, highlighting their effectiveness in the improvement of the venous outflow in the femoral veins. Our study has brought us to the following conclusion. Although all presented methods belong to VTE prophylactic methods, there are some differences between their influence on the venous outflow. The proper application of the active and passive methods should include the patient's characteristics as well as the possible range of mobilization and ambulation in the individual case. Moreover, our study shows that graduate compression stockings do not induce significant changes in the venous outflow in resting patients. Significant changes in this group was observed only when active methods such as IPC or EMS are being used. That's all from me. Thank you very much for your attention.
Thank you very much for the presentation. Now it's time for the questions from the jury.
How often and for how long this kind of prophylaxis is recommended?
This type of prophylaxis is dedicated to the typical characteristic of patients. Using graduated compression stockings is proper way to prevent deep vein thrombosis in the case of surgical patients, and this type of patients are able to move, for example, 2 days after the surgery. So, and methods like IPC or EMS are dedicated to patients who are laying, for example, patients admitted to the stroke unit. So the time of using, time of application of the device should go with the ability of mobilization during the individual cases. After the passive methods, we can perform ultrasound examination to detect potential deep vein thrombosis. But the most important thing when we use this type of prevention is to use this device in the case of patients that are able to move, because the most important thing is the activation of calf muscle pump, which improve the venous outflow in the femoral vein.
Monitoring necessary is, of course.
Yes.
Can be these methods replaced by some pharmacological treatment?
Yes, these methods are mainly used when there are contraindication to pharmacotherapy. For example, active bleeding, and the best option for this kind of patient is to use pharmacotherapy. But when there are some contraindication, we use the mechanical prophylaxis methods, or sometimes it could be combined with the medication for getting better results.
Thank you.
Thank you very much for your question. There are some evidence that using this type of prevention is an effective method in the case of surgical patients, but currently we have no evidences for their effectiveness in the case of medical patients. There are studies, for example, CLOTS Trial 1, that don't support the use of graduated compression stockings in the case of patients admitted to the hospital stroke unit. The study compared the application of the graduated compression stockings with no compression, and the study didn't show any advantage of using this type of prevention above no compression. Thank you very much.
Thank you very much for the presentation and the questions. And let's move on to the next presentation. The presentation, cause of death in patients who underwent elective abdominal aortic aneurysm surgery. Please welcome on the stage our presenter. Yes, big applause, please.
Good morning, ladies and gentlemen. My name is Zofia Kalinska, and it is my pleasure to present you our results of our research about causes of death in patients who underwent elective abdominal aortic aneurysm surgery. In introduction, I would like to tell a few words about what AAA, it is abdominal aortic aneurysm, is. It is defined as a dilatation of abdominal aorta by at least 150% according to a normal size of aorta. There are a lot of risk factors that the incidence of AAA may depend on. The most common are hypertension, peripheral artery disease, smoking, male sex, age older than 65 years, and patient's family history with AAA. And according to some research, some publications, there are big difference between mortality in patients who underwent surgical operation because of ruptured aneurysm. It's up to 70%. And in patients who underwent elective procedures, it is 2.4% for stent graft implantation and less than 5% for open surgery. And because death during elective surgery, elective medical treatment of AAA appears to be extremely rare, we've decided to analyze the most common causes of death among patients who underwent those procedures. We've analyzed histories of 24 patients hospitalized in Department of General and Vascular Surgery, Angiology and Phlebology in Upper Salesian Center in Katowice. All of our patients underwent elective procedures between 2013 and 2021. 10 of patients underwent open surgery and 14 of them underwent implantation with a stent graft. Our analysis based on the types of elective procedure the patients were undergoing for AAA and some parameters significantly influencing patients' health, such as BMI, age, concomitant diseases, prescribed medication and substances usage, and also intra- and post-operative complications. 7 men and 3 women underwent open surgery, and 3 men underwent a stent graft implantation. The age of this group of patients who underwent implantation was significantly higher. And mean BMI in both of this group in total was just slightly elevated. In the slide, you can see and the person distribution of comorbidities in patient admitted for elective surgery. In both of those groups, the significant rate of lots of comorbidities have been noticed. And here is the percent distribution of comorbidities in group of patients who underwent open surgery. The most common of them were hypertension, atherosclerosis, coronary artery disease, and dyslipidemia. And the other were chronic obstructive pulmonary disease, chronic kidney disease, heart failure, and diabetes. And in group of patients who underwent stent graft implantation, the comorbidities were very similar. However, chronic artery disease and heart failure were more common in this group. And almost half of patients had aneurysm symptoms. It is the pain associating with the presence of this aneurysm. And the most prevalent complication in all patients were acute kidney injury and acute intestinal ischemia. Other one were myocardial infarction, acute lower limb ischemia, hemorrhages, surgical wound infection, or vascular prosthesis infection, retroperitoneal hematomas and hemorrhages, and also thrombosis in the stent graft also appeared. And here you can see the percent distribution of complication in each group of patients. And in group who underwent open surgery, the most common one was hemorrhages and acute intestinal ischemia. And in group with stent graft implantation were myocardial infarction and hemorrhages. And in conclusion, in a patient with abdominal aortic aneurysm, there is a high probability of comorbidities and their complications in perioperative period. And in concluded study, it can be clearly stated that the main cause of death in all patients was the cardiovascular nature. And thank you very much for your attention, and I'm ready to answer your question.
Thank you very much for your presentation. Now it's time for the questions from the jury.
First question, you mentioned about 24 patients with complications, yes? What was the total number of patients treated and what was the mortality?
Those patients who had the peripheral?
No, what was the total number of patients treated elective abdominal aortic surgery
It was
in this period of time?
It was 24 patients we've analyzed.
You don't have data. What was the total number of patients treated with this
Unfortunately,
surgery?
Unfortunately, we don't have it because we've got exact history of patients, and we had to analyze those. There is one problem with that because we have to avoid those who had the aneurysm ruptured before operations.
Do you have any ideas why the cause are the most common causes of death, of complications? Why intestinal ischemia? Why acute renal failure?
Probably because of function of the aorta vessel. It leads the blood through the lots of organs, and while if there is some failure in this blood flow, these complications appears, and they may cause the death of the patient.
Why renal failure? What was the main cause of renal failure? Acute renal insufficiency.
I would say that it was deoxygenated of this renals.
Thank you.
Thank you.
Do we have any other questions? So thank you very much for your presentation. And we move on to our last presentation, the presentation called CRP to albumin ratio and post-pancreatic duodenectomy complication in pancreatic cancer patients. Ladies and gentlemen, the jury, big applause for our presenter.
Thank you very much. Hello and welcome, dear students, dear commission, and it's a big opportunity for me to present to you our presentation CRP to albumin ratio and post-pancreatic duodenectomy complications in pancreatic cancer patients. Pancreatic ductal adenocarcinoma is the most common common indication for pancreatic duodenectomy. It is a lethal disease with poor prognosis and with increased incidence. And surgical resections R0 remains the most important treatment to prolong survival in PDAC. But it is a complex procedure, and it is associated with high risk of complications. CAR, on the other hand, is an inflammatory based indicator connected with a poor prognosis in patients with pancreatic cancer, as well as with other forms of cancer. The aim of this study is to evaluate of significance of preoperative C-reactive protein to albumin ratio in predicting postoperative complications in patients undergoing pancreatic duodenectomy due to pancreatic cancer. CRP to albumin ratio, which we will call here CAR, is a C-reactive protein values in serum divided by albumin levels, and it has been associated with a poor prognosis in cancer patients and patients with sepsis. Moreover, CAR has been a useful biomarker for monitoring systemic inflammatory disease. However, the usefulness of assessing post-pancreatic for resection of the pancreatic cancer and its complications remains unclear. Our study group contained 38 patients, majority of which were men, and the median age was 67. And we have included to our study patients that undergone pancreatic duodenectomy between November 2018 and December 2023. Then patients with complications were then divided into two subgroups with help of ROC curve, which is a very interesting tool for us, and I will talk about it later. Majority of our patients were assessed as ASA-free, which indicates severe systemic disease, but we have also enrolled fewer number of patients with ASA2, which indicates less severe systemic disease. The most common symptoms in our patients were jaundice, which is connected with blockage of bile ducts. It is connected with mass effect of the tumor that blockage bile ducts. Also weight loss, which is also quite a common symptom for all cancer patients, and abdominal pain, which is very common in pancreatic cancer. And the less and more rarely occurring symptoms were dark urine, discolored stool, vomiting, and itching. And it's very important that nearly half of our patients does not present any symptoms at all. The most common histopathological grading of our patients was G2 pancreatic ductal adenocarcinoma, but we have also enrolled G1 and G3 PDAC, as well as intraductal papillary mucinous neoplasm. We have also checked what type of reconstruction was performed on our patients, and nearly half of our patients had Whipple resection, and another half has Traverso. We have then divided our complications into two categories: complications that were treated conservatively and complications that were needed to have reoperations. We actually have one patient that had 2 reoperations due to multiple occurring complications. And to set our cutoffs of a CAR value, we used ROC analysis, and it helps to set cutoffs and maximize sensitivity and specificity for your group. And our cutoff point were set at 0.83, as you can see here. However, it was quite unfortunate. It was quite unfortunate because even with maximized sensitivity and specificity, the majority of our complications occurred in a group with supposedly less complications, what shows the lack of reliability of such markers for assessing postoperative complications in that group. As you can see here, it is a chart that shows just that. We have also analyzed follow-up of our patient, and 6 patients had 3 operations, 1 had 2 operations. 30-day mortality in our group was 1 patient, and mortality after 30 days was 2 patients. 21 patients are still under medical supervision, and unfortunately, we have lack of information about 15 patients in our group. So in summary, the association between CAR and incidence of postoperative complications was not observed. So we advised further studies on larger groups to verify these results. And thank you for your attention. And I will now introduce the rest of my group for the discussion.
Thank you very much for the presentation, and it's time for the questions from the jury.
Interesting speech. I would like to ask, when did you assess the CRP and albumins? At the beginning, at the admission, or after the operation?
It was assessed before the operation, within 48 hours before operations.
Do we have any other questions? So thank you very much. Please applause. Ladies and gentlemen, we came to the end of our session. On the behalf of the our scientific society, I would like to thank our jury for coming to us, and thank you all for your being here, for all the participants. We came to the end, but I would like to invite all of our guests to the Rialto Theatre. Tomorrow on the 17th of May at 18th, there will be held the decoration and closing ceremony of our conference. The level of presentation that we saw today was quite high, so I think it won't be an easy task for our jury to assess these presentations. To close this session, I would like to please our dear jury for just a few words concluding all the presentations.
Thank you very much for the interesting session and interesting and valuable lectures. I think it will be in the future a possibility to conduct new investigation, and it's a possibility to develop your skills in this area. And I wish you good luck in the future in your investigations. Thank you very much.
Thank you very much, ladies and gentlemen. So officially this session is closed. Thank you very much. Drodzy Państwo, teraz jeszcze parę informacji organizacyjnych. Również chciałbym Państwa zaprosić na warsztaty, które